Well, good afternoon, everyone, and welcome to our Multi-Modality Imaging Cardiovascular Conference. It's great to start this conference. This is the beginning of our academic year, and for those of you who are joining us from abroad on the web, welcome and great to have you. Our usual conferences are for the beginning of the year, talk about the basics of each one of the modalities, then talk about cardiovascular disease and how does each one of the modalities fit in. And towards the end is maybe future directions, areas of research that we want to tackle. And I think it's very important for us to just go over all these modalities in depth. And I think at the beginning, it's very important for us to know also how does an image, how is an image created? And what are some of the advantages, maybe at pitfalls of each one of them. So let's start today with echocardiography and Doppler, some of the basics and physics. I don't have to tell you, if you've been in this field for some time, how much progress have we had throughout the years. And the amazing thing nowadays is you could see with ultrasound without any harming energy. You could see with ultrasound the heart and its structures in real time. We've evolved into a family of techniques, still using the same principle of sending an ultrasound beam or packet of sound reflected back from the surface of whatever structure you're looking at, and then characterizing it one way or another, first in space, and maybe function, and many other things that we'll talk about today. So it really has evolved into a family of techniques of Doppler, 2D, 3D, and you name it. So let's go through the principles here so we ground ourselves into some of these. One is, yes, we send packets of waves, and they're in the ultrasound range, meaning you can't hear them. They're in the megahertz, and the audible range is usually in kilohertz, right? Up to maybe 20, and if you're young, you can maybe hear it 20, but for us, getting a little bit advanced in wisdom, I would say, that we may not hear those very high frequency sounds. So a wavelength that you could see right there, that's the wavelength. It is one cycle, and the frequency is the number of cycles that are occurring per second, and the unit is hertz, after the physicist Hertz. And so the longer the wavelength, obviously the lower the frequency, and the shorter the wavelength, the higher the frequency. So when we talk about transducers emitting certain frequency sounds, you say high frequency, low frequency, and with that also goes resolution, goes penetration, energy, and so many other things, right? And that's why we have to think about those. Now, interestingly enough, the properties of ultrasound are similar to light, right? So if I send a little packet of wavelength there, it's going to hit a certain surface, and some of it is refracted depending on the properties of that surface. So if you have a surface that is very refractile, like a metal or calcium, most of it is reflected back, not much is going through. If it is water, liquid, quite a bit of that is refracted, so it keeps going further and further down. And but some of it is reflected back, and as you know, the physics, it is reflected at a certain angle, the same angle perpendicular to the surface, but most of the surfaces that we deal with are not necessarily completely flat, right? So you can have different angulations. Interestingly enough, for those of you who reflect on things as opposed to just take them for granted, is what you see, because the ultrasound, you're sending it from the same transducer. What you're going to process back, coming back, is the tiny fraction that goes back towards the transducer. So most of what you send is actually lost. Most of what you send is actually gradually dies down or is reflected somewhere else. And what you're going to see is what is reflected back, that less than 1% that's reflected back, and you amplify that with various technologies, etc. We know the speed of ultrasound in biological tissues is 1,540 meters per second. So you could surmise already that how do I know the depth of certain structures? I solve the equation for how much time did it take for it to come back, so I know what the depth is, right? So depth is not a scale of depth, it's solving the equation for whatever medium you're talking about, okay? So let's talk about also these bursts of ultrasound. So if I send a burst of a packet, we call it a packet of ultrasound, and I have two, rods, if you will. One of them is much more reflectant than the other. I'm going to have a little higher density of that as reflected back. If I look at that amplitude, right, and kind of measure the amplitude of that, the one that is much more reflectant back to me is going to have a higher amplitude, and that's the A mode. I know you don't look at those anymore. What's a B mode? A B mode is when I take this amplitude and, do a 90-degree flip towards you. And therefore, it is much more reflectant. I'll have a brighter dot compared to a softer dot, okay? Just to tell you, is 2D is a B mode, but in space. So the brighter the color, the grayscale, the more reflectant that tissue is. And an M mode is a motion mode, meaning I'm taking this dot and I'm trying to see what really happened to it in time. So in the past, it used to be printed on a sheet of paper, and and then you could see what it is. If the dot, let's say the calcification in the mitral annulus is not moving at all over time, it just stays where it is. It will be a line. But if it is a mitral valve, I'm going to go up and down. So you're going to see things that are happening over time, right? So that's therefore A mode, B mode, and an M mode. And what does it look like? Now, this is the M mode of the transducer that is put on the chest. So if I'm looking at an aortic valve, what happens to an aortic valve? This is my timing of an electrocardiogram. If the valve is closed and it's not moving much, actually it moves up a little bit, then it opens up, right? So you're going to see it here, and then there is a motion of the aorta. What happens to, let's say, the mitral valve? And if I'm looking at the mitral valve, this anterior leaflet up towards the septum, right? Then comes down, and then with an atrial kick comes back, right? And that's the posterior leaflet. So you have certain patterns that you recognize. And what's the beauty of an M mode is its time resolution. It has a very finite time resolution, okay? Now, a few things about ultrasound per se. If I go back to this packets of ultrasound, usually for you to be able to see something and decide how deep this structure is, you're not going to emit from this transducer, which has piezoelectric crystals. It's interesting. Piezo is from Greek. Tells you that is the pressure. These tiny crystals, if you press on them, either mechanically or electrically, they can emit ultrasound. And actually, they can be excited by ultrasound itself. So I send a little packet. I cannot send there all the time, because just imagine if you're in a mountain somewhere and want to reflect sound, you don't scream all the time. You don't emit sound all the time. Just a little packet comes back, then you know how deep this thing is. Same thing here is I have to send few packets at a time and wait for them to come back for me to see. If I keep sending those packets, they're going to be jumbled with whatever's reflected back, and I won't be able to tell how deep things are. So you send packets of ultrasound, and they could be maybe 3 wavelength, 4 wavelength, whatever it is, and then wait. We'll wait, right, for it to come back. And the good thing is that, it's fast enough that you'll be able to send quite a few of these. Okay, so that's the principle of an M mode. Now, how about a 2D? A 2D, well, is, think of the M mode as being on one line. A 2D, I'm steering this ultrasound beam into this space. Now, why is it in an M90-degree or so vector as opposed to a linear? Because of what the cardiac structure. So we modified it regarding cardiac to be in between the ribs. The ultrasound of 2D for vasculature or the abdomen is a linear probe, and it's flat, and it goes up and down, so you don't have to have a sector per se for you to be able to see. Here, we're trying to maximize view from between the ribs. Now, how is the image done? The image is actually done through steering, either initially mechanically, not anymore, electronically nowadays. So you could steer these beams from the emanating ultrasound here. So let's simplistically, the ultrasound goes down along this line, reflects whatever is reflecting, comes back, and I register it from the same transducer up there. Then I steer it from one side to another. So I could have scan lines. I could have almost 100 plus scan lines in this sector. Here I'm trying for delineation purposes, we're spreading them apart like this. But you could see a few things, right? Is one, that the width between these beams will be larger and larger the more depth you have, which can give you some issue down the line from a resolution point of view. But basically, this is a multitude of beam mode, right? So let's say this area is brighter than the aortic valve itself, and that's why it reflects more ultrasound, so it's more bright, et cetera, et cetera. And then I can put them in this scale depth, which is basically a scale of velocity and time, right? So that's how you put your depth together. So then I know if this is more effective, about 7 centimeter, I'm going to take a little longer for it, as opposed to a 2 centimeter depth from there. The same thing, that same principle, if you go somewhere else in the sea and you look under, if you're a fisherman and take a look at fish, it's the same thing, same principle, whatever it is, whatever you locate with ultrasound. Two important principles. There are a few principles that I'm going to highlight. One is sonographers, cardiologists, whatever it is. There's axial resolution and there's lateral resolution. Axial resolution is much better for ultrasound. If you're in the lateral plane, the resolution is much less than axial. Axial resolution is related predominantly to the frequency of ultrasound. And the question is, in any resolution, can I distinguish two dots separately? How can I know that this dot here is separate than this dot here? Okay? So go back to the principles of ultrasound. If I have a shorter wavelength, a higher frequency compared to a lower frequency, you could tell because of the wavelength that these two dots are not going to be separated. So you'll have just one dot, a large, what looks like coarse, reflected sound, as opposed to you use a higher frequency, okay? And with that higher frequency comes in an ability to separate these two, and therefore these two dots are separate. So number one, for you to have a good, nice resolution, use as much of a higher frequency ultrasound as you can get. There is a downside to it. At times, you may not have the energy to be able to penetrate that chest all the way down, and therefore that's why you can go back to a little lower frequency, which has much higher energy. Now, the beauty of your new systems is they have multi-frequency transducers. In the past, you had dedicated transducer. I had a 5 megahertz, I had a 3.5, I had a 2.5 megahertz, I have to change it. Nowadays, electronics are much nicer, okay? So axial resolution depends predominantly on the frequency. This is lateral resolution. How can I distinguish two dots that are side by side? You have usually, I don't know how many of you have looked at it, and you should actually, if this is your specialty, take a look at a phantom. And in the phantom where you test, there are pins, and you could see how much deformation these pins have, particularly if they are in the lateral resolution. And there will be, it's not a pin seen, it usually is a pin with a little spread around it. It doesn't look like a pin. And this lateral resolution depends on the width of this beam of each one of these scan lines going down. So you could tell already that, number one, this width gonna get worse and worse further down. So your lateral resolution way down from your apical area will be much worse. Now, electronically, you could focus it just like you can focus a light. You can focus an ultrasound beam and make the lateral resolution a little better. Irrespective, however, further down, lateral resolution is going to be worse. I'll give you an example of where lateral resolution becomes a problem. If you tell me I want to measure left atrial area by echocardiography, and most of them, and volumes, most of them are done from the apical window, right? The atrium is way down, and part of the lateral resolution issue is the dot becomes like a little line so that you could see encroachment of ultrasound into the left atrial cavity. And that's one of the reasons why left atrial volumes by echocardiography is less than those by, let's say, CT or MRI, and quite a difference. And to tell you the truth, just for the size, a 2 millimeter difference can be about 20 centimeter, cube, 20 milliliter difference. So part of it is that lateral resolution issue, okay? So these are the main principles for resolution because that's your image, okay? There will be another issue of resolution when we talk about harmonics. So on your machine, and our fellows or whatever it is, you need to be familiar with the machine's knobology. Each one is a little different, but the overall principle is the same. You have an overall gain. I can boost up the gain up and down. Time gain compensation, all what it is I can increase the intensity of these reflected waves depending on depth, which is the same thing as time. These dots, time gain compensation, so I'm gaining this depending on time. It's nice to see that. Lateral gain, reject compresses. All these in white as opposed to the blue are post-processing of the ultrasound beam, of the ultrasound reflections that came back into the transducer. So the only thing that really changes is the output or mechanical index that you send. So if you look at the MI or mechanical index, that's the one that how much more power do I send into this structure, into this chest. All the others are post-processing, so it's not going to hurt patients. That's why most of the regulation is in the MI itself. Obviously, you can send ultrasound in much higher power and energy to even cause lithotripsy, heat, right? Many other things can damage tissues, but this is regulated enough that it's not going to cause for this application of ultrasound any of these injurious effects for the body. And what's the mechanical index? I think that's important when we talk about contrast down the line is peak negative pressure divided by the frequency that you send. So when you look at bubbles which are much more fragile, the higher mechanical index, you basically destroy these bubbles by expanding them too much during the negative phase of this little pulse wave that you're sending. Okay? So let's talk about a few things, reverberation versus attenuation, okay? This is attenuation. Attenuation is, on this side, it's a nice thing to have the two things in the same image. One is, I have a mechanical prosthesis here, and it's reflecting so I'm sending the ultrasound here, and most of it is reflected back. If I don't penetrate and refract more going down, I'm not going to be able to interrogate that. So I'm not going to be able to see it. And the same thing is going to happen with Doppler, because Doppler is, addressing the equation of what you send out. So if all of it is reflected back, you're not going to see anything here. It'll be black. And the same thing, it will be shadowing for Doppler, color Doppler, anything. Here, you have an interesting phenomenon that is not very clear. It's called reverberations of these mechanical leaflets. Actually, between this 1 millimeter thickness, you have reverberation of ultrasound giving you not shadowing, but interference with the ultrasound beam. And that's what you're going to see not infrequently with a particular area. One is mechanical prosthesis. Now, you can have reverberations from the tissue itself between what? Between the ultrasound casing, this is where the transducer is, and some of these structures here. So some of this ultrasound can go back and forth, giving you some cloudiness. And I'm really not sure whether this is an artifact, some reverberations between the structure as well as the casing of the ultrasound versus the thrombus. And that's why you would use contrast to try, to define that. There are different ways also to, if you didn't have contrast, if you're stranded on an island without contrast, but you have your pocket ultrasound, there are ways to do it, right? You could change maybe the frequency. You could change the interrogation. I could do a short axis as opposed to apical view, so get away from the reverberations. There are different ways for you to do it, but I know you're not stranded except here in Houston, Texas. All right. For those of us who've been in the field, I don't know if Mike Quignon is here, but even Sharif Naga, I've seen some of that, but we've seen this field develop so much, and it's nice for you guys to have the feel of what really has gone on over the years. We did not have fully digital systems before. Now it is fully digital. Frame rates were lower. Quality has certainly improved. We have multi-frequency transducers that we didn't have before. Harmonic imaging came in about, I'm guessing, close to 20 years ago. We'll talk about that. Tissue Doppler, speckle tracking, this is relatively new, I would say 15 plus years ago. Digital image storage, I know in the Y2K area, we were barely in the digital image storage. Now it's everywhere. Real-time 3D echo keeps improving. It really is amazing. So it's a nice thing. And the amazing thing to me is all computer and digital technologies that have improved over time. The principle is exactly the same. It's the piezoelectric crystals that sends ultrasound in the megahertz ranges, right? For practical purposes for us, between 2 and 7.5 megahertz or so. And you get this reflected thing, and it's up to you. What do you deal with, and how do you improve on it? And it really has been amazing. So harmonic imaging, so we talked about axial resolution, frequencies, et cetera. Harmonic imaging is very important. Although it's used ubiquitously now, without thinking twice, and maybe we shouldn't think twice, maybe at least 1.5 times. At times, if things are too thick, then you may want to use it. What is it? Well, I have a fundamental frequency. Let's say this transducer is sending frequency at 3 megahertz, okay? Interestingly enough, when it hits a structure, it doesn't stay at 1 megahertz. It may actually emit different frequencies, multiple of those frequency or lesser of that frequency, and usually it's a multiple of it, right? Either multiple or a fraction of it. We thought initially that this doesn't happen in physiological tissues. Actually, this was being developed for contrast as opposed to native tissue imaging. And why? Because contrast is that little tiny bubbles with air or other carbons, fluorocarbons in it, is very sensitive to the pressure waveforms that these ultrasound will give it, and would emit a multiple of that frequency. What does it sound like? Well, I'm going to imitate it. I usually do imitate it here. If I send a frequency, bum, I'm staying at the same frequency, right? But if you do multiples of that frequency, the sound is distorted into multiple of those frequencies. It will be different frequencies, right? Some of them higher and some of them are lower. All right, so you take an advantage of this. And the interesting thing is when people use this frequency to look at tissue, interestingly enough, tissue was also emitting harmonics, not only the fundamental, and it had one beautiful thing, which decreases the noise, decreases some of these reflections that you've seen, particularly in the apical region. And that's the beauty of it. So, but there is one downside. When you're imaging at the multiple of this frequency, so this is the resonant frequency, this is the fundamental frequency, right? When you're imaging here, although it says, let's say you look at it's 3.5 megahertz transducer. Actually, what you're sending at is half, right? Which is, as we talked about, if it is 1 point, whatever it is, right, half of 3.5, if you're sending half of that, what happened to your resolution? It went down, right? So that's why at times these images would look much more coarse, and the mitral valve and the aortic valve would look thicker than what it is. So that's the downside of imaging in harmonics all the time. If you tell me our sonographers, most people in the world, what do they image? They use harmonics nowadays, but at least use the higher end of harmonics as opposed to the lower end, okay? So we talked about that, these tiny microbubbles, when you use contrast, emit quite a bit of this resonant frequency. So if you send at 2.5, they're going to emit quite a bit at 5, and the image would look quite impressive. So so this is fundamental on top. These are older images, and I wanted to keep them because from historical perspective, and still work. Same patient, fundamental on top, harmonic imaging. Watch what happened to the apex. I can see the apex more clearly, right? The image is still good in both of them, but it decreases quite a bit of this. This is contrast, okay? Obviously, contrast will have a full talking about contrast. But what I wanted to show you is this is fundamental imaging of contrast, and it's not impressive at all, right? Because you're not taking advantage of what contrast does. But if I use in the same patient, okay, well, this is just like a second apart. In the same patient, I turn to harmonic, same patient, same everything. Look at how much intensity is from the contrast itself. So you take advantage of the harmonics that are emitted, right? The second, so if I'm sending at, let's say 3.5 will be less than that, will be 1.7 something, right? And the image is much more enhanced. And then you can have a nice contrast between the myocardium as well as the contrast itself, okay? So this is fundamentals of 2D imaging. Thinking about frequency, okay? Think about harmonics. Yes, you'll use it most of the time. You may want to decrease harmonics, fundamental, in case you're seeing something that is thicker than usual and should not be thick. The use with contrast agents, so you can enhance them. And I don't think we have usually an issue with that because there are settings for contrast when you use them. So I think we're okay with that. Doppler, interesting phenomenon, okay? And we have spectral, we have color, we have continuous wave Doppler, all right, and under pulse. So what does this have to do with it? Anybody? Christian Doppler himself, right? Christian Doppler right there. So if you're in Austria, pass by. You'll be impressed by the name or where it is, but you won't be impressed of where the place is, unfortunately. Christian Doppler, we're talking about what, almost 200 years, 160 some years ago, looking at the stars and how the stars' motion changes colors and derive this amazing equation. Just imagine, being able to do that. Interestingly enough, for those of you who are interested in history and relating physics and math to other things, if you look at where Mozart was actually born and actually did quite a bit of his recitals, I'm not kidding you, is less than a block away. It's like across 2 streets from where he was born. So I said you'll be disappointed. I don't have the picture here. You'll be disappointed because it's a clothing store and a lingerie just under where this picture is. All right. So what is this Doppler thing? Simplistically, okay, if I send this 3 megahertz, which I can't hear, right? If I send it out and nothing, there's no motion whatsoever, is whatever is going to be reflected is going to be the same frequency. It's going to be 3. But if Carlos is moving, all right, he's either coming towards me or going away, the motion of this object, all right, of this person is going to shift the frequency. So it won't be 3 megahertz anymore. It'll be 3 megahertz either plus or minus. And most kind of velocities, the frequency shift becomes in the audible range. And that's why if you turn audio for a Doppler, you're going to hear. something in the audible range, okay? So that's the beauty of this Doppler is from the same, so this is asking a different question. The first question was how reflectant this tissue is and how deep is it? And what is it doing during the cardiac cycle? So I see the calcification, they're moving, and it's 10 centimeters away. That's one question. This is a completely different question. This is a question that I sent a certain frequency. I want to know how fast this thing is going from the Doppler shift. Okay? So if it is coming towards me, it's going to compress it and the frequency is higher. If it's going away from me, it's going to be a lower frequency. Okay? And the interesting thing is also dependent on angulation, right? So Main Street is out there, and there's, let's say, a train coming. If I'm on the path of the train, I can close my eyes and I can tell if the train is coming towards me or away from me, because the frequency goes up higher, 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 and then it goes away. It's going to go away from me, I know. And also I can tell if it is coming fast enough to hit me or not, because that frequency shift is much faster. All right? This is the principle of Doppler. That's the principle of Doppler. Okay? So, and I left these for historical purposes because these are hand-drawn things from Mike Quinones, none other than Mike Quinones, and I left them because that was during his lectures, and you know, he taught us many years about the principles of echo and Doppler, etc. Okay? So that's the beauty of Doppler. I can tell in the arch.
Your conference is ending now. Please hang up.
Okay. Thank you very much. So I can tell if it's coming towards me or going away from me in the descending aorta. And this is the famed equation, right? The Doppler equation. That's why you put a D as Doppler as a capital, because it's the last name of Christian Doppler. And the frequency shift, delta F, is related to the original frequency, to the velocity. So I have more frequency shift to velocity. Cosine theta, because it is dependent on the angulation, okay? And C is the velocity of sound. So all the ultrasound that you use nowadays, you look at the scale, it is solving the equation. Okay, so it's putting V as the delta F, et cetera. In the past, to tell you the truth, the x-axis or the y-axis was frequency. Okay, so we assume that cosine theta is negligible if it is less than 20 degrees or so. Okay, and the example of cosine theta being 90 degree, cosine of 90 degree is what, 0, okay? So if I'm here and the train is coming a little further away from me, although they're moving fast, I cannot tell a frequency shift. I cannot discern it because I'm perpendicular to their trajectory. Same thing is gonna happen with Doppler. So if you're perpendicular to that, you're gonna have a zero shift, right? So how much do we allow? Beyond 20 degrees, actually, you're gonna have a problem. So, but also it can tell you something about, I will talk about it in color Doppler. I can tell I have a 90 degree if the color Doppler shift is from one to color, and then you have a black in between, which is basically 0. What's pulse wave Doppler? Pulse wave Doppler. So, you know what the principle of Doppler is, the frequency shift. But if I want to know where is this frequency shift happening, all right, I want to know an area of interest. And this area of interest is, let's say, this yellow thing here, okay? So what I do, I send my packet of ultrasound, okay? I know how deep this area of interest is. I wait for it to reflect back so I know the distance, I know the velocity, and I will only listen for a fraction of a second after that time lag. Then I know the 3 megahertz frequency that I sent, how much it was shifted positively or negatively, and how much it was. That's how I can tell by pulse. And that's beauty because you're gating the range. It's called range gating. I'm gating it to where I really want it, okay? Now, obviously, you can tell that it has limitations because if the velocity is very high, if I can't, pulse enough back and forth, if the area of interest is very deep, I have to wait much longer for it to come back, right? So it's like a stroboscopic light. And that's one example, pulse Doppler in the LVR flow tract. You could see very nicely what the velocities are. This tells you about the red cells themselves, if they're going at the same speed, or this is spectral broadening. It broadens, meaning not these red cells are not going all at the same speed. Some of them are a little lower than others. Okay, that's how you do that. And then your mitral inflow, everything else, all the applications of it. This phenomenon of aliasing, meaning I cannot resolve this. And the best example is stroboscopic light. You have continuous light here, so you could see almost everything, right? But just imagine, which is pulse Doppler, I send a pulse, I wait, send a pulse, wait. It's almost like looking at Dr. Barbarian in a disco, okay? just imagine. First, just imagine. It's a stretch. But you could actually, depending on the frequency of the stroboscopic light, that he's going in a circle actually could be, going back. And that's the same thing on your older cameras, right? The cine cameras, where the frequency of the speed of the images was lower, so you could see the wheel going forward and then going back and all this, right? So this is the same phenomenon here, because what you're trying to do is, through a fast Fourier transform analysis, big word for processing of these physics, right, is to determine what the velocity is. So your frequency must be at least 2 times the pulse repetition frequency, 2 times the Doppler shift itself. You can have a little trick, just not much. You can shift the baseline so I don't know the direction. But if I know the direction already, I really don't care. I bring it down, but beyond 2 times, you're not going to be able to resolve that frequency. And that's what happens here in a mitral inflow. I can see the mitral inflow itself, but what happens in a mitral regurgitation, the velocity is very high. I can't resolve it, and that's why bipulse Doppler is going to look aliasing throughout and not going to be able to resolve anything at all. Okay? So we talked about that. What's color Doppler? Color Doppler is actually pulse Doppler, right? It's pulse Doppler, but it's a crude pulse Doppler because I have so much to process, right? I cannot use fast Fourier transform, which tells me accurately what the velocity is. I have to have just a crude estimate what the average velocity is of the result. So tell me first direction, one way or another. Is it coming towards me or going away? And give me a feel for what the velocities is, right? So what you see here is direction. If it is coming towards me, it's going to be more on the red, yellow. And if it's coming, going away from the transducer, it's going to be in the blue. And if it's going to alias, anything above 60 cms per second is going to alias and have, the mixture of colors, okay? I mean, it took forever, to tell you the truth, in the early 80s to figure out what the convention is. People wanted red going away, ultimately now, at least, we don't have too many conventions, just one, okay? So basically, you have multi-gate at every level to give you a crude estimate what these velocities are, and this is your assessment of flow within the heart, regurgitations, etc. And this is, we just talked about that. I can tell that it is not aliasing that you see, but direction change if you have between one color or the other a black marker, right? Meaning at this, I'm at 90 degrees, I don't have a Doppler shift at all, and I'm changing from coming towards me to going away from me, okay? And what influences this? This is important because it takes time to process color Doppler. And you don't want it to take so much time that it becomes stroboscopic. Then I won't know what the flow is like. So you want to maximize the frequency of these images. Yes, it is dependent on gain, color maps, frame rate is important, and the Nyquist limit. And this is an older picture where you just increase the gain, and that's the problem with color Doppler. If you're looking at aortic regurgitation, it becomes torrential here, and this is mitral stenosis. So the convention is you go to max gain where you have a lot of snow in the background, and you come down on it, so you don't have as much. Nyquist limit, if I drop the Nyquist limit, I can enhance the low velocities. I can enhance them a lot. Watch here. Nyquist limit is 21. It looks like torrential mitral regurgitation, okay? However, this is the same patient when I put the Nyquist limit where it should be, and it should be between 50 and 70, okay? And this is 57. This is your regurgitation as opposed to this. And at times you're called into the operating room or you're called into the lab, and this is not theoretical, it really has happened. Somebody has played with the machine, and then you end up with a low Nyquist limit, and then everything looks bad. And you can remedy that very quickly, right? This is important for sonographers and all of it, is what influences the frame rate of color Doppler. I want the highest frame rate of color Doppler. If I'm interrogating something close by here only, the frame rate is going to be fast because what I'm asking for processing is only this distance. If I'm looking down here, it's going to take time. So depth is one factor. Width of this sector, that's why we hone in on the area. Width of the sector will also influence it, okay? So frequency of the transducer, scan depth, width of the color, line density, which usually don't play around with. And the line density tells me how often on this line I'm going to send it back and forth before moving to the second line, before moving to the third line. If I spend a lot of time, I have more accuracy, but I will slow down my frame rate, and usually these are already put together, so you don't have to worry too much about that, okay? High PRF we're not using as much. I'm going to skip on that with the advent of continuous wave Doppler. And continuous wave Doppler, I'm sending things continuously. And I'm splitting this transducer from one sending to another one receiving all the time. And therefore, I'm not emitting pulses. I'm sending ultrasound continuously and looking for that frequency shift. What you gain is I can resolve very high velocities. What you lose is the range gating, meaning anything along this line, okay? Anything along this line will be detected, and the highest velocity will be the one that's detected, okay? So let's say this aortic stenosis with the high velocity here. To tell you the truth, it could be a subaortic membrane, could be the aortic stenosis, could be a supravalvular stenosis, okay? And at times you see those kind of things, right? At times all this is normal and you go from the suprasternal and there's some large vessel that is obstructed, etc. So you have to be careful as to making sure where things are coming from. Tissue Doppler. Well, tissue Doppler for many, many years we ignored because it was a nuisance. It was a nuisance. And we had filters because we were interested much more in the cavity than the tissue itself. And you could put filters. And actually, it's very different than what you see in the ventricle, in the blood itself. In the blood, you have high velocity, which you don't have in the muscle, right? And you have a lower amplitude because the reflection is much less. So you could filter it one way or another and say, I want blood, I want muscle, right? And here you see that this is tissue Doppler, so blood is not shown, and you're dealing with muscle. It was interesting at first, and it got more and more interesting because the properties of the muscle, be it systolic, diastolic, many other things really came from it. And we're talking about 20 years or so plus of really investigations. One is diastolic function, and I know we've contributed quite a bit to this field from this laboratory. And I think when I saw this about, my goodness, maybe 18 plus years ago, at and this abstract won a big competition, which is being able to follow the speckles of ultrasound, because tissue Doppler and velocities from tissue was available before. This was a major revolution for us because then you're not angle dependent, you're able to track. And then with tracking, you could look at function that we never were able to look at before, right? And this is strain and strain rate, okay? And why do I say that we were not able to look at before? Because strain is deformation. And what we were able to look at all the time is an M-mode parasternal log. I look at thickening of the septum and the posterior wall. That's what I could measure. The lateral walls, how I'm going to do that, I couldn't do it. The apical window, I couldn't do anything from the apical window to look at thickening, right? You had to measure the whole ventricle and all that stuff. And so now you could look at deformation from any angle, right? And strain is the deformation of this muscle, piece of muscle that could be in 3 vectors in different, yes, you look in 2D, you look at one plane of it, but it's actually being deformed in different planes. So if this is L0 and it shrinks down, so the strain is minus 20%. If it lengthens by that much, it's more than 20%. And if it doesn't change at all, it's 0%. And yes, we started with Doppler, but speckle tracking is much better. And this is strain rate, okay? So this is a slow strain rate as opposed to a fast strain rate. Still has some issues, mostly from a variability point of view. But I think if you look at properties of the heart, if you could do strain rate very well, I think that's probably even better, that strain, which is a time duration as opposed to instantaneously over time. So the 3 types of strain, I know most of you are familiar with longitudinal strain and talking about global longitudinal strain, but there is circumferential, which is the outside border, and then the radial, which is the usual thickening that we used to see that. Okay, and quite a bit of the work has been predominantly on the longitudinal strain from a prognostic point of view, and that can be done automated nowadays. You could see that very nicely with the curves, and then you can have a global strain in a normal person as opposed to this person whose heart really has had a beating. And this strain here is like minus 2%, which is almost barely alive. Digital image storage, I know we take it for granted, but I'll tell you why it is so important. And for you is ultrasound as opposed to CT and MRI, okay? Ultrasound is very dependent on the person who's taken the image, unless you're dealing with 3D acquisition. 3D acquisition, I can change the planes. This is the whole heart, I could change it. But the imaging is still not perfected as well. But in the 2D examination, you have a series of ultrasound pictures taken by you or by the sonographer. And why is it important to display it like this in a way? Is where the measurements are, where your interpretation is. There's foreshortening, there's poor image quality at times, there is respiration, there is a PVC, there is a PAC, so many other things, right? And this is the best way for you to take a look at the whole image and deciding which one you want to quantitate, which one you want to put more emphasis on in interpretation. And that's the beauty, really, of digital. In the old days, even including Dr. Naga, I think he lived some of the videotape days. I know Quinones has done that. Just imagine, your memory had to be so sharp. Otherwise, you're going to keep going back and forth on the videotape, right? So you could not blink too many times, right? Now you could blink a little more. Okay, and 3D, well, 3D, I think that's the beauty of the latest advancement. Yes, it is much better than before. I wanted to keep those because this is our first, it is around February, April 2003, okay? Time has flown by. And actually, these images are from nowadays a cardiologist and attending somewhere. We're not gonna name who this person is. Okay, but this is 3D then. And at that time, then, you had to use multiple acquisition. If you wanted to real life, the width was about 30 degrees or so only, so you could see a thin picture. But you had to do multiple acquisition. Nowadays, we still can do multiple acquisitions, but you can have a single beat, nice 3D nowadays for you. And this is how we used to be able to do it, get the whole pyramid and then cut through the pyramid for you to see this heart and then move around. But things have tremendously improved. Nowadays we have high volume rate, 3D, and you could use that for global strain, regional strain, and so many other things. And the pictures are really amazing, particularly with transesophageal echocardiography. So quite an advancement over time. And it's really nice to see of the principle, again, is still the same. It's just what technology has done. And this is mitral regurgitation. You could take a look at PISA, quantitation of PISA, vena contracta with 3D, which improves your overall quantitation. And there are some newer developments. Actually, it blows your mind. This is actually this month in JAC, first initial experience with 3D using the trans-illumination rendering. You've probably seen that. This is from Roberto Lang and Luigi Badano. Basically, you could illuminate whichever areas. You could do it behind the structure, in front of the structure, on the side of the structure. And there you go. This is a really beautiful flail of a mitral valve that you could see. And it really is amazing. So it is amazing to see from the same principle of ultrasound of where we have come from A mode to M mode, 2D, Doppler, color, TEE, contrast harmonics, tissue Doppler, live 3D, speckle tracking, live 3D TEE, and handheld ultrasound. And I think some of the applications are really tremendous in there in between. And from a historical perspective, some of you have seen this, but I'd like you to see. This is Dr. Edler, the father of ultrasound, 1960, okay, doing an echocardiogram. And this is the dress code of our sonographers. No. All right. This is Dr. Edler himself, just dipping the thing. Okay, it was not gel, it was a dip. Dr. Edler meticulously watching of what you're gonna see. And I can tell you, it is not 3D echocardiography nor transillumination. This was the excitement of the mitral valve, but this is the beginning of the field. That was the mitral valve then. And we've really come a long way. It really is amazing what you could do within just 50 plus years, almost 60 years, a really short period of time with the same principle. So thank you very much for your attention. Any questions? No questions? All right, well, we'll see you next week. Thank you very much.
I started in the second bomb of that.